Hello, hi, welcome back. So I think you can hear and see me again, no problem, right? Can you hear and see me? Anybody there? Okay, cool. Fine. So let us start from where we left already. So we have discussed on ascites. So we have discussed on the SAG ratio already and how to classify ascites based on the SAG ratio. And we are on way to the treatment of ascites. Now we are moving on to the diuretic resistant ascites. We have been discussing on how to understand the diuretic resistant ascites and how will you find out whether the patient is really having a diuretic resistant ascites or not. So I told you if you take a 24-hour urinary sodium, then we are going to see the urinary sodium potassium ratio and you're going to see the weight loss of the patient. Suppose if the patient is having a good weight loss with 24-hour urinary sodium more than 78 milliequivalents and urinary sodium potassium ratio more than 1. So whenever the 24-hour urinary sodium is high and urinary sodium potassium ratio is more than 1, I can surely tell the patient is diuretic sensitive. And because the patient is having a good weight loss here, I can tell the patient is actually adhering to low sodium diet as well. The patient is okay adhering to low sodium diet. So this is the interpretation here. 24 urinary sodium more than 78, patients urinary sodium potassium ratio is more than 1, and if the patient is not having weight loss, here it's very clearly telling the patient is still diuretic sensitive because the urinary sodium is actually quite good, but the patient is not losing weight because he is not having adherence to low sodium diet. So poor adherence to low sodium diet. Suppose in case if the 24-hour urinary sodium is less than 78 milliequivalents per day, and if the urinary sodium potassium ratio is less than 1, and the patient does not have weight loss, and this is clearly telling because the sodium excretion in the urine is quite less and the patient is not exhibiting weight loss as well, this is where we call it as typical diuretic resistance. So whenever you want to tell that the patient is having a diuretic resistance, means you always have to prove with 24-hour urinary sodium or at least a spot urine sodium potassium ratio is important to find out whether the patient is having diuretic resistance or not. So these are the major indicators that the patient is having diuretic resistance in the first place, which you really need to know. So I think hope you get it. So this is how you classify a diuretic resistant ascites. So this is the definition of a diuretic resistant ascites. In diuretic resistant ascites, you have um many different therapies for diuretic resistant ascites. So most of the time, medications that decrease the BP should be ordered because most of the time the reason for diuretic resistant ascites is due to too much activation of RAS. That is one reason, because you can also imagine like because of there is so much of hyper RAS activation, the patient is not excreting adequate sodium. So you have to avoid all medications. The number one treatment that you need to do is it's better to avoid all medications that causes more RAS activation. So what are the drugs to be avoided that causes more RAS activation? So number one, ACE inhibitors and ARBs. Of course, a cirrhosis patient will not be on ACE inhibitors and ARBs. If at all they are on ACE inhibitors and ARBs, you can uh, avoid these drugs. So these are the drugs that are going to cause more RAS activation. And typically you can think about NSAIDs because NSAIDs are known to reduce the prostaglandins and which can result in vasoconstriction. This vasoconstriction can result in probably increased hypoperfusion, resulting in increased renin release and renin activation. So probably this is also one reason why NSAID should be avoided. Beta blockers also, like propranolol, can also be avoided in that kind of a scenario. So most important drugs that you need to know is the ACE inhibitors and ARBs, which are very, very important in this circumstance. And of course, there are some drugs which you can use as a treatment option, that is midodrine, which I've told you. Midodrine will reduce the splanchnic pressure and reduce the portal pressure by causing splanchnic vasoconstriction, because this is an alpha 1 agonist, which you can try in patients with refractory ascites. And number 3, you can go for large volume paracentesis, which you do serially. Serial LVPs can be tried in low resource settings. This is the most commonly employed measure for a patient who's having a refractory or a diuretic resistant ascites, that is serial large volume paracentesis. And of course, you can try other interventional procedures like TIPS. And the final thing that you need to know, that the best treatment for any refractory ascites patient is orthotopic liver transplantation, and especially in a patient with cirrhosis, OLT is going to be the best one. So this is what we can do. And there are some experimental therapies are there. Like for example, clonidine you can try. Vaptans you can try, even though Vaptans has to be extremely carefully used in cirrhosis patients, because we know that tolvaptan, which is the commonly used, like Vaptan in practice, is heterotoxic. It's highly heterotoxic. So that is why Vaptans has to be really carefully used in patients with cirrhosis. They can create a new decomposition. That's why. And there are other interventional measures like low flow ascites pump, then hypertonic solenoid loop diuretic principle is there. These are very controversial and experimental. So nevertheless, you can understand that in certain patients with refractory ascites, clonidine and Vaptans. Clonidine is a central alpha 2 agonist. We know that. So you know how central alpha 2 agonist works. You have the synaptic terminal. There are alpha 2 receptors in the presynaptic terminal. Whenever you stimulate the presynaptic alpha 2 receptor, it actually reduces the norepinephrine release. The norepinephrine release will be reduced. So which means you can reduce the overall sympathetic tone by giving an alpha 2 agonist. Overall sympathetic tone can be reduced because this alpha 2 receptors is like a feedback receptor. So the more and more alpha 2 is stimulated, there will be reduced norepinephrine release from the synaptic terminal, from the brain itself, so that they will be resulting in a net reduction in the overall sympathetic tone. So who is asking that question? Siddha is asking ACE inhibitors inhibitors. Here it's something like otherwise. ACE inhibitors and ARBs promote hypoperfusion. So which can actually paradoxically increase the RAS here. So even though they block the RAS, ACE inhibitors and ARBs can actually increase the RAS activity and cause more sodium retention. So in a patient who's already being hypoperfused, it can actually worsen the situation. That's why ACE inhibitors and ARBs are very important in this situation. That's why I told you, even in reality, if you speak NSAIDs reducing prostaglandin I2, you have to ask, they actually down-regulate the RAS activity. And even beta blockers, you might assume that they have to reduce the renin production, but it's not like that. Beta blockers, because they block the beta 2, they produce more vasoconstriction, and NSAIDs, by causing reduced PGI2, they can produce reduced vasodilation of the afferent arteriole, and ACE inhibitors and ARBs can cause more hypoperfusion. An already dysregulated kidney, this is something that's going to happen, and you can result in development of more hypoperfusion and paradoxically more RAS activation, resulting in more problems. So that is the reason why these drugs to be avoided if at all it's been given. And nevertheless, usual common thing that is followed is large volume paracentesis. And very commonly, they will ask you that albumin dosage replacement in exam. So how much albumin you should add? That is 6 to 8 grams of albumin for every 1 liter of acidic fluid that is removed beyond 5 liters. Within 5 liters, you don't need to add albumin. So this is something that's very common in exam. So after knowing about ascites, you need to know about one important complication of ascites, that is spontaneous bacterial peritonitis, that is SBP. So SBP happens at very high HVPGs. In very late stages of portal hypertension only you get this spontaneous bacterial peritonitis. But what is the reason for SBP? The pathophysiology of SBP is because of very high portal pressures. Actually, that pushes the bacteria out of the gut into the ascitic fluid. So typically the reason is bacterial translocation that's been proposed as a pathophysiology of spontaneous bacterial peritonitis. And what are the clinical features of spontaneous bacterial peritonitis? Most common clinical feature is fever, which is seen in almost 3/4 of the patients. More than 75 to 80% of the patients will have some amount of fever, and they can develop abdominal pain. Remember, it will be like very different from that of the classic peritonitis you see. In the classic peritonitis that you see in surgery, there will be rigidity, guarding, diffuse abdominal pain, all this stuff. But here the abdominal pain may be well localized in a particular area, and the tenderness and the abdominal pain may not be that severe like what you see in the routine peritonitis in surgical cases. So this is a little different. Even small amount of abdominal pain in a patient with cirrhosis and ascites should give rise to a suspicion of a spontaneous bacterial peritonitis. And patient may have altered mental status because SBP is a very, very important trigger for development of hepatic encephalopathy. And plus or minus the patient can go for paralytic ileus and constipation itself can trigger more worsening of hepatic encephalopathy, and patients can have hypotension and shock. All these are possible, but the two most common things that in exam or in reality where you have to really think about the development of SBP is fever and abdominal pain. And as far as investigations are concerned, the most important investigation that we are going to do is ascitic fluid analysis. That's what we need to do very importantly. That's the most important here, ascitic fluid analysis. That's the most important investigation that you need to do. Where you see for the neutrophils. So how will you understand what is the type of peritonitis you have, whether it's a spontaneous bacterial peritonitis or it's a secondary bacterial peritonitis? How you really think about it? First of all, you need to understand the fact that whenever you develop ascites, on top of that you develop infection. So this is a characteristic spontaneous bacterial peritonitis. This is what we call as SBP. So if you develop infection and because of that infection you develop ascites, this is called a secondary bacterial peritonitis. So this is called different entity. That's a secondary bacterial peritonitis. So ascites first, infection next, SBP. Infection first, ascites next, it is secondary bacterial peritonitis. So this is very important to understand. Number one. So which means if the patient is already having an ascites and on top of that you develop an infection, it is actually a spontaneous bacterial peritonitis only. That is SBP. And remember here, the characteristic fluid of the ascitic fluid will not change, which means if a patient is having a cirrhosis and develops a spontaneous bacterial peritonitis, the ascitic fluid will still be of high SAG and low protein nature only. Suppose if the patient is having a nephrotic syndrome and develops a spontaneous bacterial peritonitis, the patient will be still having a low SAG and a low protein ascites only. If a patient is having a Budd-Chiari syndrome and develops a spontaneous bacterial peritonitis, the patient will still be having a high SAG and a high protein ascites only. Patient is having a malignancy, that is peritoneal deposits. On top of that, if they get a SBP, spontaneous bacterial peritonitis, the patient will still be showing low SAG, high protein ascites only, which means the development of spontaneous bacterial peritonitis will not change the characteristics of the ascitic fluid, which is a very, very important point. So which means your diagnosis of spontaneous bacterial peritonitis is based on the neutrophil count. That is very, very important. The first thing we generally look is the ascitic fluid neutrophils. How much neutrophils are there in the first place? So if it is less than 250, straight away you can tell it is not SBP. It is surely not SBP. That is why the first investigation is to look for the ascitic fluid neutrophils. If it is less than 250, it's surely not spontaneous bacterial peritonitis. So based on that, you can do culture. If you do culture, if it's positive or negative, culture means culture of the bacterium. If the ascitic fluid culture is positive, that is called as bactericytis, where there is bacteria in the ascitic fluid, but it is not creating any harm. So if the culture is negative, then it's a normal finding. So the patient is not having SBP or not having any other problem as well. If the patient is having count of more than 250, so in the sense like I can write here, I guess. So if the patient is having a neutrophil count of more than 250, so there is high likelihood of having an SBP. But here the patient may have SBP or patient may have a secondary bacterial peritonitis also. So to tell whether the patient is having SBP or whether the patient is having secondary bacterial peritonitis or not, it is better to see whether the patient is satisfying the Runyon criteria or not. So I'm going to see for the Runyon criteria. What do you mean by Runyon criteria? So one is the ascitic fluid protein, whether it is more than 1 gram per deciliter or not. Second is ascitic fluid glucose, if it is less than 50 milligrams per deciliter or not. Number 3, ascitic fluid LDH, if it is more than the upper limit of normal of the serum LDH. You can remember like it is something similar to the Lights criteria, but it's not the same. Suppose if the patient is having more than 2 of the following, more than 2 of the 3 which I have told you. If yes, more than 2 is there, then it could be a secondary bacterial peritonitis. So the next step will be likely. I'm not telling must be, likely secondary bacterial peritonitis. So then I can do a CT abdomen. Suppose in case of perforation, which is the usual cause of secondary bacterial peritonitis, or if there is evidence of any loculated infection, so then it's better to go for laparotomy surgery. So that is what you're going to do. Suppose if the patient is satisfying the Runyon criteria, then do a CT abdomen. If there is evidence of perforation or any loculated infection evidence, then better to go for surgery. Suppose if it's not the case, if the patient is not satisfying the Runyon criteria, then look for the culture. So if the culture is positive and it's showing some organism growing, then it is the definition of a typical spontaneous bacterial peritonitis. And if the culture sensitivity is negative, then you can ask about whether the patient is having recent empirical antibiotic use, because many times many gastroenterologists will start empirical antibiotics thinking it's an SBP. If yes, still it is an SBP because the culture has become negative just because you used the antibiotics in the recent times. So if it is not there, then this is typically referred to as something called a CNNS, that is called a culture negative neutrocytic ascites, CNNA, culture negative neutrocytic ascites, culture negative neutrocytic ascites, which means only the neutrophils are elevated, but culture is basically negative. That's called culture negative neutrocytic ascites. So remember how to diagnose SBP. SBP is diagnosed whenever neutrophils are more than 250 in the acidic fluid, plus not satisfying the Runyon criteria, plus the culture is positive, or culture may be negative if the patient has used recent antibiotics. These are the 4 points that you need to know to diagnose spontaneous bacterial peritonitis. Number one, patient is having neutrophils more than 250 plus not satisfying Runyon criteria. At the same time, culture is positive, showing some organism, or culture can be negative if the patient has used recent antibiotics. So this is the typical way to diagnose spontaneous bacterial peritonitis. So remember, the guidelines clearly tell whenever neutrophil counts are more than 250, whether it is a CNNA or whether it's a spontaneous bacterial peritonitis, doesn't matter. It always is associated with a poor prognosis and a poor outcome. Mortality is very high. So that is why you can start with empirical antibiotics. Not a problem at all. You can really start with empirical antibiotics in this situation. No problem. But if the count is less than 250, no empirical antibiotics. Empirical antibiotics should not be given. So which means they have a better outcome. Even bactericidis do have a better outcome. Bactericidis further treatment will be dependent on what is the sensitivity pattern of the culture. So, but apart from that, usually they have a good outcome. But whenever the count is more than 250, and if the patient is having cirrhosis, they generally have a very poor outcome, and immediately have to start with empirical antibiotics. Even SBP as well as CNNA both are associated with a poor outcome, which is very important. No, that is why this more than 250 number is a very, very important question in the exam, and it's a typical need question. So it's not like a INA CET question. No, it's a typical need question. Many times they have asked this. So what is the treatment that you will use for SBP? Suppose if you know it's an SBP or probably it's a culture negative neutrocytic ascites, what is the treatment? Treatment is antibiotics. What kind of antibiotics that you can use basically? And for that you need to know the most common organism that you're going to encounter in SBP. Most common organism that you're going to encounter in SBP is a gram negative organisms. That's what you're going to see. Anaerobic is actually quite rare. But if the patient is using some prophylaxis, for example, many times patient might be receiving SBP prophylaxis like norfloxacin very routinely. If the patient is already receiving prophylaxis like norfloxacin, gram-positive organisms may be seen sometimes. But very commonly, if they ask you most common organisms encountered in a spontaneous bacterial peritonitis, answer is gram-negative organisms only. Almost 70% of the times it will be gram-negative organisms only, like E. coli or Klebsiella. This is what you encounter. Gram-positive organisms, maybe 30% you can think about gram-positive, like Streptococcus or Enterococcus may be encountered, but this is quite rare. But you can think about gram-positive organisms if the patient is already receiving a SBP prophylaxis. Anaerobes are very, very rare. Anaerobes are very rare. Most of the times, anaerobes will be seen in secondary bacterial peritonitis. Then spontaneous bacterial peritonitis, anaerobes are very common in secondary bacterial peritonitis. But in general, in SBP, spontaneous bacterial peritonitis, we don't see anaerobes. It's less than 5%. Either gram negative, which is very common in the first attack, the patient is already receiving prophylaxis. You have to think about a gram positive organisms as well. What antibiotics you can give? Empirical antibiotics typically we give is either a ciprofloxacin, or you can give a cefotaxime. Standard dose is 1 gram 3 times a day, or you can give a ceftriaxone 2 gram once a day dose is fine, or you can give drugs like piperazolone, tazobactam. Anything is fine. Any one of these antibiotics you can use, not all, any one of these antibiotics. Yes, if it's a spontaneous bacterial peritonitis, it will be monomicrobial only. Most of the times it will be monomicrobial. Very rarely polymicrobial, but if it's a secondary bacterial peritonitis, then usually it will be polymicrobial. That's why I told you whenever I use the word polymicrobial, think about anaerobic contamination. This we have seen multiple times in pulmonary medicine in our routine app lectures itself. I've discussed multiple times. Polymicrobial means you have to think about anaerobic organisms. So secondary bacterial peritonitis is the one that very likely to cause a polymicrobial contamination or anaerobic contamination. Spontaneous will usually be a monomicrobial infection only. And what are the complications? Usual complications of SBP is HRS number one. HRS is a very, very important complication because already patients will be having a pre-renal type of failure, hypoperfusion to the kidneys. Sepsis due to SBP will increase the hypoperfusion. Sepsis is another cause of pre-renal failure, which I've seen already. So both will combine together and there is a more risk of hepatorenal syndrome and death. Okay. And this increased risk, HRS and renal failure. Or renal failure may not just be due to HRS, it can be due to sepsis itself, which can cause renal failure. So this is the most common cause of death in patients who are developing spontaneous bacterial peritonitis. And second thing is there is increased risk of hepatic encephalopathy as well because of the sepsis again. Infection itself can cause increased risk of hepatic encephalopathy because more bacteria means they're going to produce more ammonia, of course. So that is another reason why they develop death. But nevertheless, so two complications you need to know. So any patient with SBP, to prevent development of HRS, albumin infusion is a must. Generally, we give 1.5 gram per kilogram on day 1, then followed by 1 gram per kilogram on day 3, which is the standard dose for albumin infusion, which is not needed for you for exams. But albumin infusion is always advocated whenever the patient is a known case of SBP. Why you give albumin infusion? That is to prevent hepatorenal syndrome from developing because of spontaneous bacterial peritonitis. And prophylaxis. This is a very common question in exam. Remember, secondary prophylaxis for all patients, which means the patient has already experienced an attack of spontaneous bacterial peritonitis. Every single patient will receive prophylaxis, and it should be a lifelong prophylaxis because once you develop SBP, there is a lifelong risk of developing recurrent SBP, and there is an extremely high risk of recurrence. So what are the options for giving secondary prophylaxis? You have norfloxacin, extremely common drug that is used 400 milligram OD, or you can use ciprofloxacin 500 milligram once a day. You can prefer. Quinolones are the usual choice, or you can use cotrimoxazole. So if the patient is not tolerating quinolone, then Septran or Bactrim, cotrimoxazole may be a good option, TMP-SMX. So in general, the most commonly used drug in Indian practice is norfloxacin. 400 milligram once a day dose is the classic prophylactic dose to prevent SBP again. And secondary prophylaxis, all patients will be receiving a secondary prophylaxis, and most often it is lifelong prophylaxis. And primary prophylaxis is quite controversial. So when you give primary prophylaxis, which means the patient has not developed spontaneous bacterial peritonitis, but still you want to prevent spontaneous bacterial peritonitis because it is having a high risk in certain situations. What are the indications? The topmost indication is UGA bleed, because UGA bleed is associated with a high risk of developing SBP. So whenever the patient develops UGA bleed, if you take the guidelines, they would have given empirical antibiotics are very, very important in UGA bleed for multiple reasons. And the empirical antibiotics in a varicose bleed, especially in a cirrhotic patient during varicose bleed, is shown to improve survival and it's having a low mortality. So that is why in UGA bleed, definitely you have to give empirical antibiotics. If the acidic fluid protein is very low, for example, if acidic fluid protein, I think Siddharth already asked this question, it's not acidic fluid albumin here, it's acidic fluid protein, which is different. If it is less than 1.5 grams per deciliter, very low acidic fluid protein is a risk factor for developing spontaneous bacterial peritonitis. You can remember, like whenever the fluid protein is very, very low, you can understand this protein means it doesn't only include albumin, it includes globulin also. If you have low globulin, which means it's manifested by very low acidic fluid protein, it is a indication that the patient is having very low immunity in the acidic fluid. So that is why very low acidic fluid proteins may be associated with increased chances of developing spontaneous bacterial peritonitis. That's why you are giving a primary prophylaxis there. In patients who are having renal failure, suppose the serum creatinine is more than 1.2 milligrams per deciliter, or if the blood urine nitrogen is more than 25 milligrams per deciliter. So these are the situations where you can give the patients having also renal failure. In patients who are having serum sodium less than 130 milliequivalents per liter, which means hyponatremia is a risk factor for developing SBP. And patients who are having a Child-Turcotte-Pugh score, CTP score of more than or equal to 9, plus if they're having bilirubin of more than or equal to 3, so which means we are talking about almost a child class C with the bilirubin. Usually 7 to 9 is child class B only, but 9 you can think about a late child class B. So patient who's going towards a child class C plus having a high bilirubin of more than 3 is a risk factor for developing SBP. So in this situation also you can give primary prophylaxis. But the most important indication, as far as I know, is these two that are very important for exams. One is UJ bleed, and second is very low acidic fluid protein less than 1.5 grams per deciliter. So these are the two major indications for starting with primary prophylaxis for spontaneous bacterial peritonitis. Clear? So ascites is a very important topic for your exams, especially the definition of a diuretic resistant ascites and the classification of ascites is what they will ask you. And at the same time, the diuretic dosages they will ask you. And at the same time, how much albumin to replace in a large volume paracensis is what they will ask you. And what will you do in diuretic resistant ascites, serial LVPs? Again, it's a very important question for exam. And they'll ask you how to diagnose SBP, especially the neutrophil cutoff is a question that's been asked multiple times. And Runyon criteria can be a question. I don't know whether they will ask or not, but it could be a question in your exam. And what is the antibiotic choices, empirical antibiotics that they might ask you. And finally, like what are the indications of primary prophylaxis, what they will ask you. Remember, secondary prophylaxis for every single patient who have developed SBP attack at least once, but primary prophylaxis is only for some selected individuals. And hepatic hydrothorax. We have not talked much about hepatic hydrothorax. As far as hepatic hydrothorax is concerned, hepatic hydrothorax is concerned, like there are very few consensus with regards to hepatic hydrothorax. Number one, the treatment of ascites, how you treat ascites, that itself will result in resolution of hepatic hydrothorax because you have this acidic fluid that is moving into the pleural space that is causing the hepatic hydrothorax. So just treat the ascites, that itself most often will cure the hepatic hydrothorax. But most important point here to notice, never insert a chest drain. I should not write ICD because ICD always stands for implantable cardioverter defibrillator. So I can write chest drain. So the chest drain should never be inserted at any cost. So this is a very important point that you should know, because that will cause, that will cause massive volume depletion, because how much ever you remove, it keeps accumulating from the acidic fluid, and that will result in triggering more release of acidic fluid into the abdomen, and it will never end. It's like a vicious cycle. So never insert a chest drain. If at all the patient is hemodynamically unstable, having a severe dyspnea, then you can remove portion of the fluid using aspiration. That's okay. That to temporarily stabilize the patient, but never ever put a chest drain. And one more process that is avoided is pleurodesis. Pleurodesis is a commonly performed process in malignancy patients who are having refractory pleural effusions, but here pleurodesis is again avoided. So just treat the ascites. Most of the time that itself is enough to control the hepatic hydrothorax as well. And next is hepatorenal syndrome. As far as hepatorenal syndrome is concerned, the types of hepatorenal syndrome is something they're going to ask. One is a type 1 HRS and type 2 HRS. But remember, I think I've told you in the nephrology section how to diagnose an HRS. If you want to diagnose HRS, you have to rule out the other causes of renal failure. First of all, number one, the patient should have cirrhosis, or we can call it as advanced liver failure or severe portal hypertension. So I can write fully portal hypertension. Otherwise, you'll confuse with pulmonary hypertension. So the patient is having cirrhosis and portal hypertension. This is the rule number one. Second rule states that the patient should develop a new acute kidney injury as per the standard definition of AK, which I have discussed, and that is progressing. A progressive AK. So typically, you can use the same standard AK definition, either serum creatinine more than 1.5, or you can use the standard AK definition, the same definition which you have discussed in nephrology, like rise in creatinine by more than or equal to 0.3 milligrams per deciliter in 48 hours, or increase in baseline creatinine by at least more than 50% in last 7 days, or the patient is having oliguria defined as urine output less than 0.5 ml per kilogram per hour for more than 6 hours at least. So same definition you can use. Or if the patient is having a new onset rise in creatinine to more than 1.5 milligrams per deciliter, or progressive rise in creatinine, all these things will come under progressive AKI as per the HRS definition. Next thing, the patients will have features suggestive of pre-renal failure, pre-renal azotemia. Patient should have evidence of pre-renal failure. So what are the examples of pre-renal failure? The urinary sodium will be very low. Here it will be less than 10, and FeNA will surely be less than 1%, and the patient will have a Bunn creatinine ratio of more than 20. So this is a clear-cut evidence of a pre-renal failure. And patient should not have any evidence of intrinsic renal disease. Patient should have no evidence that is suggestive of intrinsic renal disease. Intrinsic renal disease. Intrinsic renal disease means it should not be glomerular, it should not be tubular as well. It should not be glomerular, it should not be tubular as well. And the patient should not have any evidence of obstruction. Patient should not have any evidence of drugs causing renal failure and all this stuff. So glomerular in the sense, I can tell the proteinuria in the urine should be less than 500 milligrams per day, and number of RBCs should be less than 50 per high per fill, and there should be literally no RBC cause. We know that. And to tell the patient is not having any tubular problem, the patient should have bland urine. I already told you what do you mean by the definition of bland urine in nephrology itself, which means the patient should not have any sediments like granular cast or RBC cast. So especially we are talking about granular cast here. And number one, patient should not have any shock or hypotension to explain the renal failure. The patient should not have any recent nephrotoxic drug use like vancomycin, gentamicin, aminoglycoside. So the patient should not have any recent nephrotoxic drug use or contrast use for that matters. And patient should not have any evidence of obstruction to tell whether it's not a post-renal failure. And patient should not have no evidence of parenchymal renal disease in ultrasound, like pyelonephritis, parenchymal renal disease in ultrasound. So, it's very easy to know. It's very easy to understand also. So even though I told you different criteria, these are the criteria to diagnose hepatorenal syndrome, but it's actually quite simple. It's just that a patient with cirrhosis and portal hypertension developing a renal failure that is unexplained by any of your routine diagnosis. That's all. Which means HRS is basically a diagnosis of exclusion. That's all. So this is what I wanted to tell. It's a diagnosis of exclusion, which means you're trying to rule out all the routine causes that causes renal failure. And if that is not the case, and the patient is having a pre-renal failure, but it's not explained by anything else apart from the cirrhosis and portal hypertension, that is what we define as something called hepatorenal syndrome. So which means HRS diagnosis is not that simple at all. So you need to wait at least for 48 hours. So, and one more criteria which I don't told you is the patient should be stopped with diuretics. So you have to stop diuretics the patient is already getting, because over-diuresis can cause pre-renal failure. Plus you give volume expansion. You know what do you mean by volume expansion? Here I'm going to use albumin only. Typical dose of albumin is 1 gram per kilogram per day. At least for 2 days I have to give. So volume expansion at least for 2 days, 48 hours. But still there is no improvement in renal failure and the AKI is progressing. So which means I have proved that the patient is not having shock, but I'm also proving that after stopping diuretics and giving volume expansion with albumin for 2 days, still my AKI is progressing, which means it is definitely not due to hypovolemia. So that's why the final take-home point is a diagnosis of exclusion. In a cirrhosis and portal hypertension patient, if you get a progressive AKI that is not explained by any other routine cause of AKI that you encounter, so this is what we define as something called as a hepatorenal syndrome in this perspective. So as I told you, there are two types of HRS. One is called a type 1 HRS and second one is type 2 HRS. Type 1 HRS is supposed to be more serious. Type 2 HRS is supposed to be less serious compared to type 1 HRS. And the AK will be rapid here. AK will be rapid here. Kidney injury will be more insidious and gradual here. It will be gradually progressive rather than very rapid progression in this situation. Typically, the creatinine doubles in less than 2 weeks. Creatinine doubles within 2 weeks. Survival is very, very low. Usual survival without treatment is only 2 weeks. Only 2 weeks they will survive if you don't treat. Usual survival here is approximately 6 months. They have a better, I'm not telling they will do well. I'm telling compared to the type 1 HRS, type 2 HRS has a better survival, approximately around 6 months without treatment. Clear? So here ascites will be very less. Ascites is not a primary feature here. So most usual reason will be infection. So one of the important precipitating reasons for developing a type 1 HRS is associated infection. Here ascites is the main reason. It will be huge ascites most of the time. Because of the huge ascites, most of the fluid is locked in the third space compartment and less perfusion to the kidneys is the main reason for developing type 2 HRS, which means the ascites is the major reason for developing type 2 HRS. Suppose if the patient is having huge ascites developing HRS, it will be a type 2 HRS. The patient is having very little ascites, but having fever and abdominal pain, developed SBP and developed HRS, it will be usually a type 1 HRS. Type 1 HRS usual precipitating event will be infection, but here there will be no precipitating cause. Usually it's the ascites itself that will be the usual reason for developing type 2 HRS, which is refractory and massive most of the times. So massive ascites, refractory ascites, getting a kidney injury. In exam, you answer type 2 HRS. Infection precipitating HRS and rapid increase in creatinine, think about a type 1 HRS. Clear? As I told you, treatment is terlipressin and albumin. You can prefer alternative to terlipressin is norepinephrine. Suppose if terlipressin is not available and the patient is in ICU, then alternative to terlipressin will be norepinephrine. And usually you have to give 2 weeks of treatment. They might improve or they might not improve. Suppose the patient does not show any much response, then next option is to go for TIPS. Suppose if you want to ask the best treatment for refractory HRS, once again answer will be orthotopic liver transplantation. That's going to be the best option. But HRS as such is quite simple. The 2 points that I want to stress again is it's a diagnosis of exclusion, and type 1 more serious, type 2 less serious. Type 2 ascites is the primary problem. Type 1 ascites is not usually primary problem. It's the infection that causes the problem, and treatment is terlipressin plus albumin. Alternative to terlipressin is norepinephrine, especially in ICU patients. So this is what is something I needed to tell as far as HRS is concerned. And there are some important other pulmonary complications of portal hypertension. Hepatic hydrothorax, which I have already discussed. 2 more things is hepatopulmonary syndrome and portopulmonary hypertension. 2 things are there. For both these things, pathophysiology is completely unknown. But we clearly know that the main problem in hepatopulmonary syndrome is vasodilatation, and in portopulmonary syndrome is vasoconstriction. So how it causes vasodilation, how really it produces vasoconstriction here, we don't know. And in both these situations, endothelin 1 levels are extremely high. Endothelin 1 levels are actually very high. But how the same endothelin, it produces vasodilation in hepatopulmonary syndrome and vasoconstriction in portopulmonary hypertension, we don't know. But probably there could be some unknown factors like genetic factors like BMPR2 mutations which can produce portopulmonary hypertension. So that is yet to be discovered. There are more papers that are available, but nevertheless, that is not important for you in the first place. That is something which you need to know for sure. Just hold on. Okay. So, but clearly the primary problem in hepatopulmonary syndrome is vasodilatation, and primary problem in portopulmonary hypertension is vasoconstriction. So you know what's going to happen here. If the pulmonary vasculature, let us draw the alveoli first. Alveoli. And let us take this as normal capillaries. And let us take another alveoli. If there is a massive vasodilatation here, so what happens is the gas is coming here and the number of RBCs that are moving on will be typically saturated with oxygen, not a problem at all. But in this example, in the second example where you see a massive vasodilatation, there will be more blood flow across the pulmonary vasculature, so that the amount of gas exchange that is happening can only, saturate with oxygen with, these RBCs, and these RBCs are basically not getting saturated with oxygen, which means I can draw in blue, which means these are still deoxygenated. And you know very well that whenever deoxygenated blood is moving to the right side, this is the left side and this is the, right side and this is the left side, which we have discussed already multiple times in the past. So whenever a deoxygenated blood moves from the right-sided circulation to the left-sided circulation directly without getting oxygenated, so this is what we called as shunt formation. So that's what is happening here. So because of severe vasodilatation, this results in development of shunt formation. So that is the basic pathophysiology of hepatopulmonary syndrome. So that's why they develop hypoxemia and low saturation. And in this patient with vasoconstriction, the main problem is VQ mismatch. So there is low perfusion here. So you have VQ, there is a good ventilation, but very low perfusion is there. So typically the VQ ratio will be more than 1. So which means the main problem here it's happening is VQ mismatch and not shunt formation. It's the VQ mismatch that is happening. And at the same time, because of vasoconstriction, there will be increased resistance to blood flow across the pulmonary vasculature. So this increased resistance will increase the right ventricular pressure, and the right ventricular will go for pressure overload. So increase RV pressure, which results in RV hypertrophy over a period of time, and that will result in RV failure over a period of time. So that is what is going to happen in these patients with portopulmonary hypertension. So for example, if you take the chest x-ray, so basic things is like these patients will show increased vascularity because of more blood flow that is happening because of vasodilatation. But these patients will show oligemia, reduced vascularity, because there is reduced pulmonary blood flow. There will be reduced vascularity in this kind of situation. So basically, contrast echocardiography is what we do. We inject some bubbles or some contrast substance. So contrast echocardiography is something that is very helpful in differentiating these conditions. Suppose if you put a contrast in, some air bubbles or something, if you inject into the blood, or some saline, some bubbling saline, if you inject into the blood. So in a patient who's having hepatopulmonary syndrome, they will be seen on the left side of the heart very, very fast, because whatever you're injecting into the veins, that goes into the lungs through the right ventricle. And if suppose the blood moving into the right ventricle is too much, so it will go very fast and come back into the left side very fast. So usually within 3 beats, that's what we calculate. So within 3 beats, usually, your substance that you have injected will come on the left side. So that is diagnostic of a shunt formation, hepatopulmonary syndrome. Suppose if it takes a long time to come into the left side, then that goes more towards a portopulmonary hypertension. And at the same time, portopulmonary hypertension will have other evidence of high pulmonary resistance, like right ventricular hypertrophy, pulmonary artery systolic pressure will be very high, mean pulmonary artery pressure will be very high. So you can use even echocardiogram to make a diagnosis. But more importantly, here you need what? Contrast echocardiography to pinpointly tell that the patient is having increased pulmonary perfusion or not. And at the same time, clinical features, which we forgot completely. What are the clinical features of hepatopulmonary syndrome? More importantly, these patients will be asymptomatic. I've seen plenty of hepatopulmonary syndrome patients who will be completely asymptomatic. Plus or minus, they can have dyspnea if at all they are symptomatic, but very commonly they'll be asymptomatic. They won't have any problem at all. But classically, there will be one word that will be given in textbooks is orthodeoxia. Orthodeoxia is very classical of hepatopulmonary syndrome. And any shunt formation, orthodeoxia is very, very common. And in patients with pulmonary AV malformation, the first paper that told this word orthodeoxia is actually described for pulmonary AV malformation, which also shunts the blood from pulmonary artery to the pulmonary vein directly. So orthodeoxia is a manifestation of shunt formation. That's all. The classic condition is pulmonary AV malformation, but it can happen in patients with any other cause of shunt formation like hepatopulmonary syndrome as well, where that deoxygenated blood directly goes into the left side without getting oxygenated. And you can get platypnea. Platypnea is also another classic sign of a shunt formation. What do you mean by platypnea? So plat means flat and pnea means breathing, which means flat breathing. The patient is feeling better when they lie down, because when the patient gets up, they get desaturation. So because of that, the patient tends to lie down. So that is what we call platypnea. So they breathe better and the saturation is maintained better when the patient lies in supine position, which is quite opposite to what is in pulmonary edema and many other lung conditions. And clubbing is quite common. That is because of AV shunting again. And the patient will not develop any low cardiac output symptoms. In fact, the patient's circulation will be hyperdynamic, pulse will be bounding because of high circulation, high pulmonary blood flow that is moving into the left side as well. And here the patients will become symptomatic very fast and the patient will become early dyspnea. You can remember, like pulmonary embolism patients, because of high pulmonary vascular resistance, they go for early dyspnea. And more often they will not have this orthodeoxia, they will have orthopnea. Very importantly, they will not have platypnea. Orthopnea is classic. What do you mean orthopnea? Ortho means erect and pnea means breathing. The patient feels better on breathing with erect posture, which means the patient tries to stay erect. When they lie down, they get more breathing difficulty. And at the same time, the patient will get low cardiac output symptoms because of severe pulmonary hypertension. The blood flow through the pulmonary circulation to the left heart will be less, so they can develop syncope, fatigue, lightheadedness. These are extremely common in this situation, which is very uncommon in the hepatopulmonary syndrome side. Treatment: you can try giving LTOT, long-term oxygen therapy, but it will not work because we have discussed multiple times in pulmonary medicine chapter in the routine lectures, where shunt formation will not respond to 100% oxygen. You can try LTOT, but it will associate with a very poor response. But the only definitive treatment that you can give is orthotopic liver transplantation. That's the only definitive treatment as far as HPS is concerned. So when you go for portopulmonary hypertension, So you can use standard pulmonary artery hypertension management. Standard pH management can be done. So where you can give vasodilators and all this stuff. Plus oxygen therapy may be useful because oxygen tends to vasodilate the circulation. So it will be helpful to some extent. But again, the definitive treatment is orthotopic liver transplantation only. So this is the definitive treatment. So what is the triad? So final nutshell is the triad of hepatopulmonary syndrome. The patient tends to have liver disease, number one, and patients will have elevated AA gradient, typically defined as more than 15. Anything more than 12 is little abnormal. So typical patient will have hypoxemia with elevated AA gradient, and the patients will have IPVD, that is intrapulmonary vasodilatation. Typically, this can be proved by contrast echocardiography. Depending on how fast the contrast reaches the left side of the heart, you can tell this. So if you have these three things, this is very characteristic feature of a hepatopulmonary syndrome. So what is the classic triad of a portopulmonary hypertension? Portopulmonary hypertension classic triad is the patient should have a liver disease, of course, and the patient should have evidence of pulmonary hypertension, that is mean pulmonary artery pressure more than 15 millimeters of, 25. We have discussed this multiple times. Whenever the mean pulmonary artery pressure is more than 25, that is suggestive of pulmonary hypertension. And of course, we have to prove that this is not due to raised or due to left heart disease. To prove that this is not due to left heart disease, PCWP is less than 15 millimeters of mercury is what you have to prove. So to prove all these things, you need a right heart catheterization, which is considered to be the gold standard for diagnosing portopulmonary hypertension. So the most important investigation or the most important diagnostic investigation for hepatopulmonary syndrome is contrast echocardiography. The most important or diagnostic investigation for portopulmonary hypertension is right heart catheterization. This is what you need to know in the first place. So this is easy to understand, not a big deal at all, but the pathophysiology is completely unknown. Even though if you have interest, you can go through the papers that are given in multiple journals, but I don't think that really is important in management or even for exams right now. So do you understand what is the difference between hepatopulmonary syndrome versus portopulmonary hypertension? If you understand so, then we can move on to the next topic, that is hepatic encephalopathy. Okay. So this is going to be the major difference between hepatopulmonary syndrome versus portopulmonary hypertension. So let us move on to hepatic encephalopathy now. So what are the things that precipitate hepatic encephalopathy, and what are the reasons in developing hepatic encephalopathy, and how to treat the hepatic encephalopathy, and what are the clinical features and staging system that you have for hepatic encephalopathy. This is the final thing which we'll be discussing. Variceal bleed I will teach you separately in the UGA bleed section, because you need to correlate with the peptic ulcer bleed as well as for the variceal bleed in a single sitting. So we'll discuss separately. So hepatic encephalopathy, remember, it's a sign of liver failure. It is not a sign of portal hypertension. So it's not a direct complication of portal hypertension. It's a complication of hepatic failure. That is one thing that you need to know, which I have discussed multiple times in the past. And second thing is, what is the reason for developing hepatic encephalopathy? Number one, the proteins that you take in that diet. That is what is going to be the most important here. Basic substrate for production of ammonia. Who's going to produce this ammonia? The intestinal bacteria. The bacteria that is present in the intestine. The gut bacteria is the one that is going to convert this proteins to ammonia. Normally, in the presence of a good liver, normal liver, so this ammonia will be converted to urea in the urea cycle. Everyone knows that. Suppose the patient is having a liver failure, which is significant enough so that there will be accumulation of ammonia. This accumulation of ammonia is the one that is going to result in hyperammonemia, and this is the main problem that causes hepatic encephalopathy. Number one, ammonia is known to directly produce astrocyte damage. Directly, they're toxic to the astrocytes, and there will be something called Alzheimer type 2 astrocytes, and that is due to damage from ammonia and hepatic encephalopathy. Whenever there is a damage from ammonia and hepatic encephalopathy, and you have a characteristic type of astrocytes in brain biopsy that's called Alzheimer type 2 astrocytes. This is the pathophysiology, and nobody is going to do brain biopsy for diagnosing hepatic encephalopathy, of course. And those type of astrocytes are called as Alzheimer type 2 astrocytes, and it's nowhere related to Alzheimer disease. The name it's called as Alzheimer type 2 astrocytes, that's all. And this hyperammonemia will serve as a substrate for excessive conversion of alpha ketoglutarate and glutamate to glutamine, because if you take the process alpha ketoglutarate, they can convert to glutamate, then they can convert to glutamine. And remember, to produce these substances, the main substrate is ammonia. So if you have excess ammonia, alpha ketoglutarate can be converted to glutamate, and glutamate will get converted to glutamine. So remember, there are two things that are happening. One is reduced alpha ketoglutarate because of excessive ammonia, and second is increased glutamine. Both are dangerous. So reduced alpha ketoglutarate means alpha ketoglutarate is a very, very important substrate for Krebs cycle to produce ATP. So the patients tend to have low ATP production in this situation. And number two, more glutamine is osmotic. And because they are osmotic in the brain cells, they draw water from the surroundings, and that will result in development of cerebral edema. So two problems. So anyway, so we are talking about the pathogenesis of hepatic encephalopathy. And remember, it's not only ammonia, it's been related to many other substances that are completely different, and you cannot really know about all those things, and you need not really know about those. But more importantly, not only this alpha ketoglutarate and glutamine, even it is supposed to be that GABA increase has been thought to be one of the main reasons for developing hepatic encephalopathy as well. So low ATP, high glutamine causing cerebral edema. At the same time, GABA excess has been also thought to be one of the main reasons for developing hepatic encephalopathy. Clear? So what are the precipitating factors? So what are things that precipitate the development of hepatic encephalopathy? Let us see one by one here. So the first one, conditions, whatever conditions that increase the proteins. Remember, whether you take more dietary protein or not in cirrhosis is a very controversial thing, because patients with cirrhosis will have very low albumin levels in the blood and very low protein production from the liver. And that is the reason why cirrhosis patients tends to be cachexic. They won't be well built at all. They'll be very thin. Their edema may be there, but peripheries and all will be very thin because of the hypoproteinemic state. And a patient who's not having any encephalopathy, and if you're giving less proteins to them, means it's actually not good, because they'll go for more cachexia, and that's that's a counterproductive thing. So it's not a good thing to do. So that is why guidelines clearly tell, if the patient is having hepatic encephalopathy, during that time of acute stage of hepatic encephalopathy, you can go for low protein diet. But if the patient is not having any evidence of acute hepatic encephalopathy right now, you need not give low protein diet. It's better to always stick on to the normal protein diet that you generally follow in patients with hepatic encephalopathy. I mean normal protein that you follow in all other patients. Only during acute hepatic encephalopathy, you generally tend to give low protein diet. Apart from that, once the patient recovers, don't restrict the proteins too much, because otherwise they'll go for severe cachexia, because already the liver is not producing any protein. Coupled with that, if you give very low protein diet, means it's not good. So now the main precipitating event that increases the amount of protein load in the gut is UGA bleed. Very, very important point. It's very common in patients with cirrhosis and portal hypertension, and that can result in development of high protein in the gut, because this blood is nothing but full of proteins. RBCs also contain proteins, WBC also contain proteins. When they are digested, you are going to release a massive amount of protein that serves as a substrate for conversion to ammonia by the bacteria. So of course, UGA bleed is a very, very important precipitating cause. Then infection. So you can think in infection, probably the number of bacteria is increasing. So probably that you can remember like that. So especially very common infections in patients with cirrhosis are spontaneous bacterial peritonitis, or probably sometimes even urinary tract infections. But SBP is extremely common, which can precipitate the development of hepatic encephalopathy. And third thing is hypokalemia and metabolic alkalosis. Hypokalemia and metabolic alkalosis. Multiple reasons for that, because I think we have already studied multiple times in the previous lectures that hypokalemia directly increases renal ammoniogenesis. I don't know how many of you have listened to this. Hypokalemia directly increases renal ammoniogenesis, and hyperkalemia tends to reduce the renal ammoniogenesis. So because the patient is having hypokalemia, it can directly increase the renal ammoniogenesis. And we all know that hypokalemia can maintain metabolic alkalosis, and we have studied that as well in the previous lectures. So what are the mechanisms behind that? Hypokalemia can actually maintain the metabolic alkalosis in the body. So they do have metabolic alkalosis. And what is the problem in metabolic alkalosis? Because ammonia ammonia conversion is always in equilibrium. So whenever you develop alkalosis, whenever you give an alkaline environment, there will be more conversion of ammonium towards ammonia. Suppose if you have acidosis, there will be more ammonia to ammonium conversion. So acidosis will produce more ammonium and alkalosis is going to produce more ammonia. Suppose if the patient is having metabolic alkalosis, they tend to produce more ammonia. And that is also one reason why they develop hepatic encephalopathy when you get a metabolic alkalosis. All these things, basics we have discussed already, so there's no need to tell anything. So renal failure, very important. Clear? Because renal failure, you can remember like kidneys also excrete a lot of ammonium. So we know that. So kidneys, especially if you take the proximal nephron, PCT, they produce ammonia. This ammonia we have discussed already. It comes to the distal part of the nephron like collecting duct, where it removes H plus and becomes ammonium, and that will be excreted in the urine as ammonium chloride. We know that this mechanism we have studied in nephrology itself. So in renal failure, this ammonia cannot be utilized, and this accumulation of ammonia will be there in the body, and that's why renal failure, in one way you can remember that it can precipitate the development of hepatic encephalopathy because of accumulation of ammonia. It reduces the kidney's ability to utilize ammonia. And hypovolemia, and of course hypovolemia will activate RAS. Once it activates RAS, it's going to produce more hypokalemia and metabolic alkalosis. We know that aldosterone's main function is to reduce potassium and to initiate a metabolic alkalosis. So RAS activation is going to be problematic. And hypoxia, once again, if you're using sedatives, especially benzodiazepines, especially most important example is benzodiazepines. That is why in hepatic encephalopathy patients, you should never give benzodiazepines, even if they are aggressive. Even if they're behaving aggressively, never give benzodiazepines, because I told you one of the important neurotransmitters that are associated with development of hepatic encephalopathy is GABA. Benzodiazepines being a GABAergic drug, so definitely they will worsen the hepatic encephalopathy. And hypoglycemia definitely increases the GABAergic activity, and reduces the ATP production. They can worsen hepatic encephalopathy. And number 9 is constipation, very, very important. In constipation, the contact with the protein and the bacteria will be more, because the bowel movement is not happening that frequently. So the protein and the bacteria will come into contact for a longer time. So there is more production of ammonia in this situation. And high protein diet, again, controversial whether to use what protein in a liver failure patient. Remember, don't use high protein diet, but you can use a normal protein as long as the patient is not in hepatic encephalopathy. During hepatic encephalopathy, give low protein. If the patient is not in hepatic encephalopathy, give normal protein, but don't give high protein diet. High protein diet can produce more risk of hepatic encephalopathy. And the patients, if they develop portal vein thrombosis, or if the patient develops hepatic artery thrombosis. I'll ask you trivia. Suppose a patient is having a cirrhosis, and if they develop portal vein thrombosis or hepatic artery thrombosis, what will you suspect? What will you really suspect in this scenario? Anyone who's intelligent can answer. It's a very simple question. So patient who's having a cirrhosis develops portal vein thrombosis or hepatic artery thrombosis. It should not happen, isn't it? Because liver failure patients generally tends to have coagulopathy, more INR. So whenever they have coagulopathy, thrombosis is supposed to be uncommon. Suppose a patient with cirrhosis and a liver failure develops portal vein thrombosis or a hepatic artery thrombosis, what do you suspect? What is the next thing that you should suspect? Anyone? Who wants to answer? Is there anyone there, first of all, to answer, or nobody is there? It's looking dead silent. Buchari. Ankit selling Buchari? No. You can answer me, no problem. So it's not Buchari. The next thing is always suspect hepatocellular cancer, HCC. HCC is very important. The next thing you have to suspect is hepatocellular cancer and malignancy. Very, very important, because hepatocellular cancer is known to cause this, venous invasion and arterial invasion. So think about HCC, because the single most important cause of hepatocellular cancer right now in the world is cirrhosis. Background cirrhosis, irrespective of the cause, you always have a risk of HCC. That's simple as that. So cirrhosis developing portal vein thrombosis, hepatic artery thrombosis, it is equal to HCC unless proved otherwise. The next step is to always go for a triple phase contrast CT. So contrast CT is the gold standard for diagnosing hepatocellular cancer. And as for the clinical features is concerned, the staging system is very important. There are two staging systems are there. The commonly used staging system is the West-Haven staging. That's what we use. But the most accurate is the 4-score. There is something called as the 4-score. That is the most accurate. That's called full outline of unresponsiveness. Full outline of unresponsiveness is what we refer to as 4-score. But the most commonly followed scoring system is staging system is West-Haven staging system. Based on the West-Haven staging system, I can tell the grade of hepatic encephalopathy. Like for example, based on consciousness, based on intellect and behavior, and based on the neurological findings in examination, we can tell the grade. And pupillar response, which is very important. Pupillar response also is there here. And apart from that, what is the risk of cerebral edema? You know the grade now, but hepatic encephalopathy's major risk is to develop cerebral edema. So what is the risk of cerebral edema in these situations? So you have stage 0, where the consciousness will be completely normal, intellect and behavior will be completely normal. The patients may have a completely normal clinical examination, but with one exception, they may have impaired psychomotor testing. Like they may have problems in that constructional apraxia. That's why a very common question in exam is, what is the first thing to happen in a patient with hepatic encephalopathy is constructional apraxia. This kind of psychomotor testing alone may be abnormal. The patient may not be able to do it. So that is the very earliest thing that happens in hepatic encephalopathy. And pupillar response will be completely normal and there is no risk of cerebral edema. So this is the first stage, impaired psychomotor testing. That's the first thing that happens in hepatic encephalopathy. And most important is the constructional apraxia, that connecting the numbers, otherwise referred to as number connection test, which everyone would have heard about that in your final year. So then we have stage 1 hepatic or grade 1 hepatic encephalopathy, where the mild lack of awareness will be there. Mild decrease in awareness will be there, but overall this is very difficult to find out in reality, and attention span will be little reduced attention span. The patient will not listen to you for a long time. If you speak to them, their attention will keep on going to somewhere else. So that is one of the first things happens in stage 1. And the patients will be finding difficult to do some mathematical problems like addition, subtraction. This will be showing errors. Patient may not be able to do good mathematics, and patient may have mild flapping tremors, asterisks, mild flaps may be there in this situation, and the pupillar response will still be normal, and risk of hepatic encephalopathy is still there, but it's extremely rare to get hepatic encephalopathy. A cerebral edema in this situation. Risk of cerebral edema is there, but very rare to get cerebral edema. And second stage, the grade 2, the patient will be more lethargic and patient will start getting disoriented, but it will be very subtle disorientation, and the patient will be more going for inappropriate behavior. They may not behave properly. They will try to go out when you're speaking. They will immediately try to get out and go out of the ward. So this kind of inappropriate behavior will start, and the patient will have obvious flapping tremors, and speech will be slurred. They cannot speak properly, and the speech also might become completely inappropriate. And pupils will show a very brisk response, even though in exam you can remember as normal, but I will suggest it's a brisk response. If you are able to pick up, it's fine. And the risk of hepatic encephalopathy is the cerebral edema is still there, but it's still rare. Grade 3 and grade 4 carries a higher risk of cerebral edema compared to grade 1, grade 2. So here the patient will be sleepy all the time. It's not only lethargic, patient will be sleeping, but still arousable. You can wake up the patient, but they'll be sleeping all the time. There will be gross disorientation and a very, very gross, bizarre behavior will be there. They will try to hit the wife. They will try to hit everyone, staff nurse. So very gross, inappropriate behavior will be there. And they can see rigidity and muscular rigidity and clonus may be there in examination. And increased deep tendon reflexes is a very characteristic feature of grade 3 hepatic encephalopathy. And there is a high risk of cerebral edema here. And pupils we not discussed about. Pupils as such will be showing a very sluggish response, and there is a high risk of cerebral edema. Approximately 30% of these patients will develop cerebral edema if we don't treat them. And finally, grade 4, completely comatose patient, not arousable, So there is no point in telling anything here. The patient will go for posturing. Typically, the decerebrate posturing is common than decorticate posturing, and pupils will be dilated and fixed. It will not react at all, and there is an extremely high risk of developing cerebral edema here, appropriately up to 70%. In fact, if we don't treat them, all 100% will develop cerebral edema. So typically, sleepy arousable grade 3, coma grade 4. Not sleepy, but still finding a little weak and lethargic grade 2. Overall normal patient, but only mathematical problems, then you can go for grade 1. Everything normal, just psychometric testing alone is abnormal, it's grade 0. So remember, this grade 0, grade 1, where you don't see any obvious problems in the patient, I mean by interacting with them, is what we called as a covert hepatic encephalopathy. That's called a covert HE. When the patient gets some gross problems like disorientation, that is supposed to be overt hepatic encephalopathy. So only in examination you get some problems. Apart from that, everything is normal. That is covert. If the patient is grossly disoriented, by the way they look itself, you can find out in hepatic encephalopathy, means it's a straightforward. And the name suggests that it's a overt hepatic encephalopathy. And you have three different types of hepatic encephalopathy that is postulated. One is a type A hepatic encephalopathy, then you have a type B hepatic encephalopathy, then you have a type C hepatic encephalopathy. Type A hepatic encephalopathy is something that happens in acute liver failure. You can remember the mnemonic very easily. Type C hepatic, hepatic encephalopathy happens, again, a mnemonic is there, where it happens in the setting of cirrhosis. And if you get hepatic encephalopathy in this setting, that is called type C hepatic encephalopathy. Type B hepatic encephalopathy, the patient is not having ALF and not having cirrhosis, but still they develop hepatic encephalopathy due to some other cause of portosystemic shunting. There are many other causes of portosystemic shunting which we have discussed already. If you get because of that, then you can think about type B hepatic encephalopathy. So the mnemonic is very clear. So type A is for ALF, type C is for cirrhosis causing hepatic encephalopathy, and type B is not cirrhosis, not ALF, but some other cause of portosystemic shunting causing hepatic encephalopathy. That is type B. Diagnosis of hepatic encephalopathy is mostly clinical. One of the important markers that you need to know is serum ammonia as a diagnostic marker of hepatic encephalopathy. Remember, ammonia is extremely sensitive and it has a very high negative predictive value to diagnose or rule out hepatic encephalopathy, but it's having extremely low specificity, which means a normal ammonia virtually rules out hepatic encephalopathy. This is very, very important. If you have a normal serum ammonia, it rules out hepatic encephalopathy. But if the patient is having elevated ammonia, it does not correlate with hepatic encephalopathy, which means ammonia elevation can be seen in multiple other situations, even in other metabolic encephalopathies. At the same time, elevated ammonia does not correlate with the severity of hepatic encephalopathy as well. If the ammonia is 200, 300 against a normal value of 30, again, it doesn't tell you that the patient is having severe hepatic encephalopathy. So ammonia levels very poorly correlate with severity. At the same time, a normal ammonia definitely rules out hepatic encephalopathy as a cause of patient's altered behavior. So it's more sensitive and has a high negative predictive value rather than specificity. So it's like a D-dimer, you can imagine. The normal D-dimer rules out a venous thromboembolism. Similarly, a normal ammonia rules out hepatic encephalopathy, but raised levels are not specific for hepatic encephalopathy. At the same time, they very poorly correlate with severity of hepatic encephalopathy as well. You have a new marker which is coming up, but it is not available commercially. That is called 3-nitrotyrosine. So this could be a question, like I told in heart failure, there is something called a soluble ST2, which is a new marker that is coming up for the diagnosis of heart failure. Similarly, this 3-nitrotyrosine is an upcoming marker for hepatic encephalopathy, which has a better correlation with hepatic encephalopathy compared to ammonia. And we have a lot of variety of tests we have for clinical tests we have for diagnosing diabetic encephalopathy, hepatic encephalopathy. The most important is the constructional apraxia test, that is called Retan's number connection test. You know how to do that. You have 1, 2, 3, 4 different numbers, like up to 80, 70 also is there available. So you ask the patient to combine all these numbers, just to combine. So 1, you have 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, probably 12. So you combine this. So there are separate charts available for this. This is what we refer to as a Retan's number connection test, REATAN. So which is a very important psychomotor test for hepatic encephalopathy, and many scoring systems are there. So what is the typical finding that you see in the EEG? Anyone? So these are questions for the audience. So what is the EEG finding of hepatic encephalopathy? That's very commonly asked in exam scenarios. Anyone? EEG findings. We have discussed it already, isn't it? EEG findings in hepatic encephalopathy. In CNS we discussed, man. Already in EEG I discussed that already. Anybody there? Again, I want you to ask if anyone is there. Yes, Pranavi has told the right answer. Answer is triphasic waves. EEG shows triphasic waves. Again, I have told you there itself in CNS, triphasic waves are not specific for hepatic encephalopathy. It is just suggestive of hepatic encephalopathy. It can be seen in any other metabolic encephalopathy as well. And now coming on to the treatment of hepatic encephalopathy. Treatment of hepatic encephalopathy. As far as the treatment of hepatic encephalopathy is concerned, number one, always correct precipitating causes. There will be definitely underlying precipitating factor will be there. You have to correct the precipitating factors. And number two, even if the patient is agitated, never ever use benzodiazepines. This is very, very important because many of the patients will be very aggressive and irritable and disoriented. So to control that, don't use benzodiazepines. Use alternative drugs like haloperidol if you want. So, but never use benzodiazepines. They precipitate and worsen the hepatic encephalopathy. And third is drugs that you can use to control hepatic encephalopathy. The most important drugs and the first choice drug we always use is lactulose, or probably you can prefer even a lactitol. Both are almost the same. So you know how lactulose works. As I already told you, ammonium conversion is dependent on the pH status. The ammonia is basically produced in the gut by the bacteria. And remember, under acidic environment, we all know that ammonia that is produced by the bacteria will become ammonium. So that's what lactulose does. So lactulose basically, or lactitol basically creates an acidic environment in the gut that results in production of more ammonium than ammonia. Whatever ammonia may be there, that is getting converted to more ammonium. And this more ammonium in the sense like once these things are happening in the gut means, remember the fact that only ammonia can move out of the gut. Ammonium cannot move out of the gut. This is a very simple pharmacological rule. I think you know. Ions cannot move out of the lipid bilayer or move into the lipid bilayer, which means this ammonium will not be able to go out of the gut and they will be trapped within the gut, and which will be basically excreted in the stools. So which means basically you are preventing the absorption of ammonia by converting this ammonia to more ammonium by giving an acidic environment in the form of lactulose. This is the major action of lactulose. Apart from that, lactulose has a natural laxative effect. It's very important laxative also, where the stool transit will be faster so that the amount of contact of the protein in the gut with the intestinal bacteria will be much, much lesser. That is also the reason why they produce reduced amounts of ammonia. So two things. One, they reduce the production of ammonia by increasing the stool transit by having a natural laxative effect. Second thing, whatever ammonia is formed, most of them will be converted to ammonium, which cannot be moving across the gut and that will be excreted in the stools. So thereby having a beneficial effect on hepatic encephalopathy patients. So typically, what is the target for giving lactulose? How much dose you can give is approximately you can give up to 90 ml of lactulose you can give, but we generally start with 30-40 ml of lactulose per day we start with, but you can titrate up to 90 ml per day of lactulose. But please understand the target for lactulose is at least 2 to 4 soft stools. Remember, when I was starting my PG life, when I was a postgraduate, my seniors used to tell that you make the patient go for diarrhea. So once the patient gets diarrhea with lactulose, then hepatic encephalopathy will resolve. No, that's not correct. That's wrong, because getting diarrhea is not the target there. If you get the diarrhea, it might result in more volume loss, and hypovolemia will still precipitate more and more development of hepatic encephalopathy. So it should not do, because in the precipitating factors I clearly told you, hypovolemia is a precipitating factor for hepatic encephalopathy. So don't let the patient go for diarrhea, but we actually aim to achieve at least 2 to 4 soft stools per day, not diarrhea. The patient gets diarrhea means try to stop lactulose because it's too much. So it's a natural laxative, so it will cause diarrhea if it's too much. So try to down titrate the dose and make the patient pass at least 2 to 4 soft stools per day. It's not diarrhea. Clear? So, and second is gut sterilization, which means one way is to prevent the production of ammonia. Second is to sterilize the gut and make them free of bacteria. The bacteria is the one that creates the nuisance, and destroy that bacteria. The first choice drug that we use is rifaximin. That's what we use. Previously, we have been using neomycin, which is no longer used because of the toxic profile of neomycin. We don't use this anymore, but typically we use rifaximin. Rifaximin doses either 550 milligram 2 times a day or 400 milligram 3 times a day. It's a standard dose of rifaximin, but you can use. Neomycin can produce nephrotoxicity and ototoxicity because it's an aminoglycosid antibiotic. We don't use it. Low protein diet. I mean, remember, reduced protein diet should be given only during the time of hepatic encephalopathy. Once the patient recovers from hepatic encephalopathy, don't give high protein diet, but you can give a normal protein diet. Then there are other experimental therapies are there, which may or may not be beneficial. For example, we have LOLA. What do you mean by LOLA? It's called L-ornithine and L-aspartate. Very simple. Ornithine and aspartate are basically substrates for the urea cycle. In fact, very important substrates of the urea cycle. So when you give this ornithine and aspartate, the urea cycle may be accelerated. Once the urea cycle is accelerated, they will consume more ammonia, thereby reducing the blood ammonia. So that's one way. Probably it's again experimental, not having good evidence in hepatic encephalopathy, but still it's very commonly used by many gastroenterologists. And we have branch chain amino acid infusions, BCAA. So I mean, there are again many research-based evidences for this rather than actual clinical evidence. Whether they are really beneficial or not, we have no idea. But still, we use branch chain amino acids very, very commonly. So why? Because in patients with hepatic encephalopathy, there are more aromatic amino acids. Due to unknown reasons, we don't know the exact reasons why there are more aromatic amino acids. Phenylalanine, tyrosine, tryptophan are the basic aromatic amino acids. In patients with hepatic encephalopathy, there are supposed to be more aromatic amino acids than branched amino acids. Usually in the blood-brain barrier, these aromatic amino acids actually compete for the branch chain amino acids. So there will be more entry of aromatic amino acids into the brain compared to that of the branch chain amino acids. Inside the brain, that branch chain amino acids are supposed to be lesser in patients with hepatic encephalopathy. So this is also postulated to be one of the reasons: increased aromatic amino acids and less branch chain amino acids in the brain. So this can be reversed by giving more branch chain amino acids, so that when you increase the level of branch chain amino acids in the brain, research evidence is telling that you are having some benefit in terms of hepatic encephalopathy improvement. And again, it's a research-based theoretical evidence, but we don't have any clear-cut practical improvement in many of the scenarios. That's why it can be tried, but if you don't want, you can leave if it's not available in your center. Then we have something called sodium benzoate and sodium phenylacetate is there. Phenylacetate is there. And if you remember, in biochemistry, you would have studied these drugs. So these are the drugs that are typically treated in patients who are having urea cycle defects, congenital urea cycle defects. Again, the mechanism of action is complex and again experimental drugs, but they are highly approved for treating urea cycle defects which happens in a congenital fashion causing hyperammonemia. But in patients with hepatic encephalopathy, it is quite experimental. And flumazenil has been tried because GABA is a very important neurotransmitter. If you want to stop to prevent the action of GABA, you can give flumazenil, which is a benzodiazepine receptor antagonist. Zinc again is supposed to be experimental. Melatonin has been tried, which is again experimental. Then drugs like memantine, which is used in Alzheimer's disease, has been tried, again experimental. L-carnitine is very commonly used, again, which is experimental. So all these are experimental drugs. LOLA, BC, branch chain amino acids, sodium benzoate, sodium phenylacetate, zinc, melatonin, memantine, carnitine, all are experimental drugs. But in common practice, very commonly we use LOLA. L-ornithine L-aspartate is very commonly used drug, really very commonly used drug in clinical practice. But apart from that, the most important, we have typical clinical trial-based evidences, lactulose and rifaximin. So very, very important drugs. No hepatic encephalopathy regime should have drugs without lactulose and rifaximin, which is very, very important in treatment of hepatic encephalopathy. I think this will help you in understanding the complications of liver failure and portal hypertension. Nevertheless, do you understand? So that we can move on to the next topic. Hepatic encephalopathy. So most of the times in patients with hepatic encephalopathy, what are the questions you will get in exam? In exam, you will get the precipitating factors. So if you want to know only one thing in exam, always know about the precipitating factors, which are going to be the most important. So this is a very, very important question in exam. And apart from that, the treatment is what they're going to ask. treatment wise, this lactulose and rifaximin, definitely they will ask. Apart from that, other questions you may or may not get, but precipitating factors and treatment, never forget. All the precipitating factors should be in your fingertip before going to the exam, because that's a very common question in exam. Clear? Do you understand? And one question I have got, now only I'm seeing anonymous. Okay. So they posted the question as anonymous. Could you please explain why aesthetic tapping is contraindicated in patients with hepatic encephalopathy? Once again, because of fear of hypovolemia. We have discussed already, no? Of course, your removal of acidic fluid will result in some element of hypovolemia, especially in the setting of hepatic encephalopathy. Hypovolemia can result in development of hepatic encephalopathy because of the hypovolemia induction. So that's a very simple thing. So that's not a very tough question, by the way. So I got a question some time back. So that's why we don't do acidic fluid tapping in patients with hepatic encephalopathy. Do you understand? Anyone there? Do you understand, so that we can move on to the next one? Okay. So you got it. So the next topic we'll be discussing is on the difference between the NCPF and EHPO, because these two are very, very important. So how to diagnose a non-cirrhotic portal fibrosis, and we have something called extrahepatic portal vein obstruction. Then we have cirrhosis also. How to differentiate between these three. It's very difficult in reality, but there are some theoretical points that you should know. So non-cirrhotic portal fibrosis means it's a portal vein problem, idiopathic fibrosis of the portal system without any cause. Typical of NCPF, but there will be some evidence of liver failure in NCPF also, which we'll be discussing in some time. So what are the age of the patient? Typical age of the patient in NCPF, typically around 30 years, classic age, around 30 years. EHPO, children, 10 years, and cirrhosis, typically they develop around 40 years. But it is highly variable, but NCPF, young adults, cirrhosis, a little old adult, and EHPO, typically children. And what is the gender, male-female ratio? Typically, the males are very commonly affected in NCPF. Once again, EHPO, the male children are very commonly affected compared to that of the females. And cirrhosis as such, once again, males are more commonly affected than the females because of the alcohol, which is very, very important, and HbSAg, which is also very common in males. And what is the site of portal hypertension? We know it is intrahepatic, but pre-sinusoidal. It's not pre-hepatic, it's intrahepatic pre-sinusoidal. Pre-sinusoidal. It is actually pre-hepatic. It's typically pre-hepatic or extrahepatic, which means what is the difference between NCPF and EHPO is, in NCPF, you are going to have fibrosis of the portal system that are small vessels. They are not macrovascular fibrosis. It's a small vessel that is going to get fibrosis. The peripheral portal vein branches, small branches. After entering into the liver, that small branches will go for occlusion. So that is NCPF. But in EHPO, the macrovasculature, the portal vein itself will go for obstruction, like a portal vein thrombosis. So that is where the problem is. And in cirrhosis, it's intrahepatic only, but it is sinusoidal. Clear? So what will be the site of portal vein blockade? Portal vein blockade. What will be the site? So here I cannot tell because there is no portal vein blockade at all here. But in the patients with NCPF, it is peripheral small branches. Peripheral small branches, that is the one that is occluded in NCPF patients. In patients with EHPO, it is the main portal vein that will be blocked, or a confluence of the portal vein formation, like splenic vein with the superior mesenteric vein joins, that is the point where they can go for block. So main portal vein is the usual. It's a macrovasculature that is blocked. Incidence of GA bleeding. GA bleeding is basically less frequent, and at the same time, they'll be well tolerated. Well tolerated in the sense, even if it happens, they will not decompensate. In the sense, they will not go for hemodynamic instability. So it will be a little bleeding only, and it is very uncommon. Similarly, GA bleeding is less and well tolerated even in EHPO patients. Whereas in patients with cirrhosis, it is extremely frequent and recurrent and poorly tolerated. UGA bleed in cirrhosis patients is not that easy. Most of the time, there'll be hemodynamic instability, decompensation, encephalopathy, HRS, so many problems they'll go for. So it's not a good thing to happen in a cirrhosis patient. Encephalopathy, it's very rare, but can happen. Rare can happen, but it's extremely rare. But encephalopathy is extremely common in hepatic encephalopathy, cirrhosis patients, because it's a direct damage to the liver parenchyma. Remember, even in NCPF and EHPO, there will be some damage to the liver cells, because sometime back I also asked you a question, which is the most important blood supply to the liver. Everyone answered that it is portal system. That is the most important blood supply to the liver. 80% of the blood supply for the liver is actually done by portal system only. But if there is any damage to the portal system, the liver will go for ischemia, and the liver parenchyma will not be normal even in patients with NCPF and EHPO, which means there will be very subtle, not like cirrhosis, but there will be very subtle liver failure that will be there in patients with NCPF also, which means NCPF characteristically, if you take the classic theoretical definition, there should not be any liver parenchyma damage, but it's only the problem in the portal radicals. But in reality, because of the portal radicals, because of the reduced perfusion to certain areas in the liver, because of the problem in the portal circulation, the liver cells may not be functioning completely normally like what is seen in normal patients. So there will be some element and some evidence of liver failure will still be there in certain patients, so which can become obvious in the later stages of the disease. So what I can tell is, in cirrhosis, there will be overt liver dysfunction, but in NCPF and EHPO, there will be a covert, maybe a subtle liver dysfunction may be there, which may not be very, very obvious. So that's why I'm telling you, encephalopathy is rare, but still can happen. Clear? And what about jaundice? Jaundice is once again rare, but still can happen in very late stages of the disease, where they go for severe liver dysfunction because of the ischemia to the liver over a period of time. Still, it is very rare here, still can happen over a period of time, but we know jaundice is extremely common because of liver dysfunction. And ascites and pedal edema. Ascites and peripheral edema and pedal edema. So very, very rare here because liver is okay till the last stage. Rare here because liver is okay till the last stage. Extremely common here. And what about that spider navy? And again, it's a sign of liver failure. Very rare. You don't get very rare. You don't get. It's very common here because it's a sign of liver failure. And what about splenomegaly? Remember, splenomegaly is a sign of portal hypertension, not liver failure. So usually it will be very massive in this setting. More than 7 centimeter, moderate to massive splenomegaly is quite common in NCPF. It will be there, but it will be moderate splenomegaly, only less than 7 centimeter. It will be there in cirrhosis. Cirrhosis will usually produce a mild splenomegaly less than 5 centimeter only. And typically liver function test will be normal till the last stages. In late stages, it can go for jaundice and abnormal LFT. But I mean, most of the cases at presentation and for a long period of time, LFT will be normal, but differently LFT will be abnormal here. And when you do imaging typically will show splenomegaly here, splenomegaly, and there will be no evidence of cirrhosis, and at the same time there will be peripheral pruning of portal veins, especially in the setting of angiography. When you do an angiography, there will be peripheral pruning. So in the sense, like the portal vein will divide into two like major vessels, and after that abruptly they will start diminishing in size. So this is called peripheral pruning, typically referred to as something called as a withered tree appearance. Withered tree appearance. And as far as NCPF is concerned, extrahepatic portal vein obstruction is concerned, it's a very important diagnosis that can be done only through angiography. Usually there will be splenomegaly in imaging, and there will be, of course, no evidence of cirrhosis. The liver parenchyma will look normal, not nodular. But in angiography, you will see this cavernomatous transformation. Cavernomatous transformation of the portal vein. This is the hallmark of the extrahepatic portal vein obstruction. So the only difference that you can make through investigations between NCPF versus extrahepatic portal vein obstruction is the cavernomatous transformation of the portal vein in angiography in extrahepatic portal vein obstruction, and withered tree appearance that you see in angiography in patients with NCPF. So this is what the classic finding. And of course, you will see nodular liver here. You can have splenomegaly, but nodular liver clearly tells that the patient is having a cirrhosis in this setting. And when you do a liver biopsy, It will be completely normal because the problem is not in the liver at all. It is in the portal vein in EHPO. Here you will see a portal fibrosis. The portal veins, especially the peripheral branches, the small branches of the portal veins would have gone fibrosis, and that's what is very obvious in patients with NCPF. And here you will see, like collagenic bands, nodules. So very classic of a cirrhosis. And if you take hepatic vein pressure gradient, it will be completely normal in both the situation because pre-hepatic, pre-sinusoidal, we told HVPG will be normal. In cirrhosis, HVPG will be increased. As far as prognosis is concerned, okay, bad, poor prognosis. Cirrhosis does not carry a good prognosis, but NCPF and DHPO overall carries a better prognosis. And treatment as such, initially the most important is a variceal management. Varices treatment is more important. You can treat with propranolol or you can treat with banding. So you can do some variceal management because this is the most important problem that they encounter. If it doesn't respond, then probably you can go for orthotopic liver transplantation in advanced stages. If they have liver failure in advanced stages, then you can go for orthotopic liver transplantation. And in patients who are having EHPO, the most important treatment is again varices management by giving propranolol and all this stuff to reduce the portal pressure. But remember, TIPS is something impossible in both these scenarios because it's pre-sinusoidal and HVPG being normal, it's very difficult to do a TIPS. And there is no need to do a TIPS. I mean, NCPF, but here TIPS can be done. So I'll tell you how TIPS can be done in some time. But TIPS can be done to an extent here, but TIPS is impossible. You cannot do TIPS here. And at the same time, OLT is also not useful because it's completely a portal vein problem. OLT is not possible. But alternatively, you can do something called a REC shunt. Alternative treatment is something called a REC shunt is there. So I'll tell you what is the advantage of doing a REC shunt. So here you will do cirrhosis management, standard cirrhosis management, which we have been discussing for a long while. So how TIPS is possible, let me tell you. So when you take a liver, so where is the problem? So you have a spleen here. So you have a splenic vein which combines with inferior mesenteric vein, and then you have a superior mesenteric vein. Together they form the portal vein. So once they enter the liver in the portal vein, so they form these small radicals. So these are two main branches of the portal vein. From there you get multiple branches. So where it end up with this microvasculature. The problem in NCPF is this small vasculature, this peripheral vasculature that are going to go for fibrosis. So this is NCPF. But whereas in patients with extrahepatic portal vein obstruction, the problem is in the main portal vein. It's at the confluence, usually at the junction of the splenic vein with the superior mesenteric vein. So this is where the problem is. This is the portal vein for that matters. So this is where the problem will be, usually in patients with EHPO. So whenever you are doing a shunt, TIPS, it's difficult, but still you can do. So you can actually, because of the increased portal pressure here, if you have increased portal pressure in patients with NCPF, you can actually combine the hepatic vein connect the hepatic vein with the maybe one of the branches of the portal vein. To an extent, you can shunt because the problem is in the periphery, so it will not be a big problem. But in patients who are having extrahepatic portal vein obstruction, literally it is not possible. So because the portal pressure that is increased will be proximal to this area, here is where the portal pressure will be increased. That is the reason why you have a splenomegaly and varicose bleed and all this stuff. But it's literally impossible. So even if you connect with the hepatic vein and the portal vein, because the problem is at this place, you will not be able to shunt the portal pressure appropriately. So TIPS is literally impossible in patients with HPO, where even though it's technically demanding and challenging, it is to an extent possible in patients with NCPF to some extent. So that is what you can do. So clear? So I think now you can understand the difference between NCPF, EHPO and cirrhosis. So how will you understand in exam? So what is the clinical scenarios that you'll get in exam? Cirrhosis, classically the patient will be having hepatitis B virus or a hepatitis C virus or a chronic alcohol use. Some history will be there in exam for sure. And this patient develops complications of cirrhosis like ascites, varicose bleed, hepatic encephalopathy. So clearly you can tell that this patient is having a cirrhosis. So this is scenario number 1. So where you can diagnose a cirrhosis easily. And NCPF, how will you diagnose? NCPF, typically patient will be a middle-aged man. That's what commonly they will give, middle-aged male, who's presenting with a massive splenomegaly. Massive splenomegaly. Plus, they will come with a varicose bleed. Varicose bleed, it will be easily controlled. But the question clearly tells there is no jaundice. Patient is having a normal liver function test, no problem at all, which means normal liver function means including PTANR, everything will be normal. And at the same time, there will be no evidence of hepatic encephalopathy as well. So this is very, very characteristic of NCPF. Sometimes this massive hemophilia, because of hypersplenism, you might get anemia, thrombocytopenia can be there. That is because of hypersplenism. Increase the sequestration of the blood cells within the spleen can happen, but you should not think about any hematological condition. If they clearly give this history because they are presenting with varicose bleed, this should be going towards NCPF. If the same history, if it goes for children, if you get a child with maybe around 5, 10 years or 15 years or 20 years, maybe young children, if they come with splenomegaly, developing a varicose bleed, and they do have evidence of hypersplenism as well. And once again, if you don't get a jaundice and hepatic encephalopathy and patients having a completely normal lefty, including a normal PTANR, this is typically going towards a extrahepatic portal vein obstruction. Ideally, to differentiate these two apart from the age, you need this angiography where you see cavernomatous transformation in patients with extrahepatic portal vein obstruction, where you see this peripheral pruning in patients with NCPF. That is the ideal way to differentiate between NCPF as AHPO. But in reality, in exam or even in real-time clinical practice, it's the age is the one that's usually going to typically differentiate these two disorders from each other. Cirrhosis is very easy to pick up, but NCPF and AHPO, in reality, they are very, very easy to pick up. So children, adults. Children or adults both having the same presentation, massive splenomegaly or a good splenomegaly with a varicose bleed, normal lefty, everything else is normal. Endoscopy showing varices, go for NCPF or AHPO. In exam, the only thing that differentiates is the age. But the best definitive thing that is needed to differentiate is the angiography that you need to do. Clear? So what is a reg shunt? So we didn't talk about the reg shunt, isn't it? So, I told you there is an alternative called as reg shunt. So what is basically a reg shunt? Reg shunt is like a iatrogenic shunt that you are basically going to use by, used to, like communicate with the superior mesenteric vein with the one of the branches of the portal vein. So because we know the obstruction here, we need to bypass this obstruction by shunting the blood from this area to this area. And they do really well with this shunt. So even though this has some complications, this is what we refer to as something called as a Rex shunt that is used for extrahepatic portal vein obstruction. So what do you mean by Rex shunt? Rex shunt, other name is mesenterico left portal bypass. So it's very simple. It's mesenterico, which means superior mesenteric vein to the left portal vein. So mesenterico left portal bypass is what we typically call it as a Rex shunt. Do you get it? So where you use Rex shunt, white tips is impossible here. White tips can be done, but still with a difficulty. Cirrhosis, you know already. So do you understand this? So what is the difference between NCPF, AHPO versus cirrhosis? In exam, both are important questions. NCPF and AHPO both are important. Do you understand? Clear? Okay, cool. Fine. So let us take a short break and I'll tell you the time in the group. So we'll come back by maybe 10:15 maybe. So I'll start the session again. So after this, I think we are going to do with varicose bleed, and after that I'll be starting with viral hepatitis maybe. So very important topic for you, and I think we'll be completing in a couple of hours. And with this, I think the liver will be over. If at all tomorrow possible, I'll complete some malabsorption, hepatocellular cancer and all this stuff, and some metabolic liver disease and autoimmune liver disease also will do if there is time. So next topic will be varicose bleed and viral hepatitis. Both are very important. So stay tuned. I'll come back at maybe 10, 10, 15. I'll inform in the group. Let us take a short break. Bye-bye.